This is a 62-year-old man. During the medical checkup, he screened his thyroid gland by ultrasound. He came here after being told to get tested at a large hospital because he has a nodule in his thyroid gland. The 1.2 centimeters echogenic nodule was seen in the left thyroid gland. On the external ultrasonic reading sheet, it was recorded as a calcified node. Based on what we learned earlier, let's look at the rear shade of this echogenic lesion together. With this ultrasonic image, the dark clean shadow is suspected in the back, so there seems to be a possibility of calcification. But the images from my hospital were different from the previous images. You can see a dirty shadow behind the lesion, which suggests an error. Why does the shadow look different with the same nodule? As you all know, ultrasound is operator dependent. Even for the same nodule, there are many mechanical reasons, such as ultrasonic setting, angle of transducer, and degree of compression. But the most important thing is an examination that reflects the experience, knowledge, and thoughts of the examiner. The image is the most representative one traced among the numerous image information that the examiner has seen. In ultrasound examination, artifact is also used as an important clue for diagnosis. So we need to carefully perform ultrasound from various angles to know which artifact is at the time of examination. This lesion is located below the thyroid cartilage and includes air, so we thought of the esophageal diverticulum first. However, no matter how closely we looked at the ultrasound, we could not see the connection with the surrounding esophagus. The location of the lesion was also slightly different from that seen a little further back in the cross-section in the case of the esophageal diverticulum. I explained to the patient that this lesion is not a lesion diagnosed with an FNA while ultrasound is performed because whatever it is, it should not be FNA. Then, in the case of esophageal diverticulum, I will show you how the connection to the esophagus is shown in the ultrasound through a video of another patient. This patient was diagnosed with right cancer at an outside clinic, and FNA was referred for left lesion for operative extent determination. If you are experienced doctors in this field, I think you should not stab it with a needle even with an image from the outside clinic. In the transverse scan of ultrasound, a connection to the esophagus behind a small hypoechoic nodule right in front of the esophagus is seen. And in the longitudinal scan, it looks like a lump inside the thyroid gland. Since the nodule is a three-dimensional form, it is common for the position to look different depending on the angle. I'll show you an ultrasound video. You can see the connection to the esophagus on the ultrasound. So, if you have knowledge of the lesion, you can easily diagnose the esophageal diverticulum using ultrasound alone. Let's come back to the image of the patient earlier. This patient has no connection to the esophagus, so we need to think of another lesion that could contain air in this location. On CT, an air pocket was seen in the upper left thyroid, and we considered the possibility of a piriform sinus fistula. It was diagnosed with a piriform sinus fistula in the esophagogram. If we review the ultrasound image once again, artifacts taken on ultrasound will also reflect the examiner's thoughts. This is the case that shows the importance of knowing the possibility of various diseases when performing ultrasound. If we review it for a while, the piriform sinus fistula is used collectively as the third and fourth branch cleft anomalies. As I mentioned earlier, inflammation of the thyroid gland is not common. So if there is recurrent inflammation, you should consider the possibility that this disease may be underlying. Characteristically, if a child has recurrent inflammation of the thyroid gland, the disease should be considered. There is no clear standard for the classification of the third and fourth branch cleft anomalies so far. And there is no significance in classification from the perspective of treatment. Therefore, many literatures have recently named the third and fourth branch cleft anomalies as piriform sinus fistula. The previous patient has been doing well for over 60 years without any problems. Rather, if you had done FNA or core biopsy with the next step by performing ultrasound, the problem could have been significant. This study analyzed piriform sinus fistula in Korean patients. Most were children, but there were also patients in their 50s. It is mainly prevalent in the left. This is an example of a typical piriform sinus fistula. A 5-year-old boy visited the hospital with neck pain. Ultrasound shows a hypoechoic lesion in the left thyroid and infiltration in the periphery. CT shows left thyroid mass with adjacent inflammation. Coronal view suspects fistula below left piriform sinus. After checking the fistula's tract on pharyngography, the hole was blocked and treated with TCA chemocauterization. Afterwards, the lesion improved. The next case is a young woman. After the thyroid nodule FNA, she visited the emergency room with neck swelling, pus on the area where she was stabbed with a needle, and worsening pain. A hypoechoic lesion is visible inside the thyroid gland and is connected to this lesion, spreading inflammation to surrounding tissues, including muscles. The patient had a neck ultrasound at an outside clinic because she complained of neck discomfort. And then she proceeded with FNA after finding a thyroid nodule. A mixed echoic nodule is seen on US from the outside clinic before FNA. You can see an echogenic portion inside the lesion, which it is difficult to distinguish whether it is colloid or air. It seems almost impossible to diagnose a piriform sinus fistula only with this ultrasound image. CT shows abscess at left thyroid and inflammation of surrounding tissue. The patient was cured after treatment with PCA application to the left piriform sinus opening with the lesion excision. In the piriform sinus fistula, CT is better than MRI because air is important for diagnosis. If you see a fistulous tract, it is easy to diagnose, but it is not always visible. It is often found due to frequent inflammation on the left side. But if screening US is implemented as it is now, there is a possibility that it may be accidentally found, like the man in his 60s. It is often treated by preventing the opening of the fistula, and in severe cases, surgery is also performed.